going to talk about um, adolescent onset schizophrenia and the developmental issues that come with that. Keep in mind that I'm thinking adolescence moves up into the early 20s because our brains are still well developing up into that time. So the most important things really that we were going to talk about is differential diagnosis. We're going to take a look at good old Erickson's developmental stages and how that fits into thinking about the formulation. Just a real quick note on antipsychotic medication and what it does to the metabolism for teenagers. And just a real quick thing on treatment strategies. This is a pretty long PowerPoint, so I'm going to whiz through it. There are handouts that I've created, and on the slides where there's a handout, you'll see a red stamp that says there's a handout on this, and you will get that for your own perusal. So adolescent onset schizophrenia really means that this prodromal start happens before the age of 10. Very, well, that's not necessarily true, but onset prior to 10 is extraordinarily rare. It does certainly happen. Most of it happens in early adolescence, and it presents very differently in adolescence than it does in adulthood. So when we begin to see these prodromal features, we don't really know what the course of the disorder is going to look like for them. The younger, of course, a client is, I think overall it's harder to diagnose and treat quickly and because we're fearful of putting the wrong diagnosis on a young person, and that's a valid fear. So it may be a one-time thing, but it also may be something that is gonna invade this person's life and their family's life for their lifetime. We also want to make sure that this is not a diagnosis that is really secondary to some underlying diagnosis when it shows up this early. We also now need to think about drugs and trauma. Even just watching the TV set, good heavens, yesterday morning I was watching the news and nearly burst out into tears just from watching the news. So, you know, even media can cause some real fear and panic. Can we diagnose an adolescent using adult criteria? Yeah, we can. There was a great study, the Maudsley study, where we took a look at these things, and diagnosis was applied retrospectively, and 83% of the time that diagnosis was accurate for affective psychosis. A third of the time it was good for affective schizophrenia. 80% of the time it was good for schizophrenia. So there is a 20%, which is a significant amount, that really was due to some other disorder. So it's still a significant gap, but most of the time we can hit the mark with the adult criteria. So we just want to be really careful about that. Just because an adolescent is reporting a hallucination doesn't mean that schizophrenia is on the way. Everything needs to be couched in terms of what developmental stage this person is in. If they're just having magical thinking or wishful thinking, if they've been in trauma and are wishing, you know, that they were part of some other family. There are also some cognitive difficulties that become evident most of the time. Usually, you'll see that as the disease or as the condition progresses and it becomes noticeable, that that's a sign that something may be to come. So adolescent onset schizophrenia is really known to be have poor premorbid functioning. You should be able to see this. They're scared. They don't want to go to school. Maybe they're fearful people are following them. Maybe a real bullying thing has happened. And we do know that bullying can actually be a causative factor. That kind of trauma can be a causative factor in developing hallucinatory and psychotic experiences later on. Some of the common delays that we see are language, reading, sometimes even bladder control. And we also see the IQ is down about a whole standard deviation. So it's very insidious. It's hard to see. You know, adolescence, I think, can be a diagnosis in and of itself sometimes. And when I looked at that and treated adolescents in that way, it became more fun, I think, to treat the adolescents. But their job is to test the limits. That's their God-given job. And so it's really hard to figure out what's testing, what's risk-taking, and what's really not well behavior. The symptoms can come and go. Of course, there's substance abuse involved, so you have to parse that out. There can be social impairments that you'll want to take note of. And a lot of times parents don't catch that, or they think of their child as just a loner or introverted or something like that. But if you see something in an adolescent that gives you the notion that maybe there's some social difficulties there, social functioning difficulties, you may want to follow that up. Of course, there may be other mental health issues in the family and trauma, and we do need to always keep in mind that concept of cultural humility and how that affects how we treat the family as well as just the adolescent. In fact, there was a family that I was dealing with, an agency was dealing with a family where the family was very culturally involved with their previous culture. The adolescent had become pretty westernized, and it was just a very hard dichotomy for that young woman to process through. So following the symptom pathway, we'll see like non-specific behavioral changes, but it's, you know, out of character for the person. It's generally not like with drug use where it's either horrible or great change. It's, you don't really know what to assign it to. It's kind of odd. Adolescents tend to have more negative symptoms than adults do. And so it can look like adolescents sleeping in until noon. That's a lot of adolescents do that. But we'll see that kind of sitting quiet, not moving, wanting to isolate a little bit. The positive symptoms aren't terribly well defined like they are with adults. The delusions are kind of not holding together very well. They're nonsensical. And if there's auditory hallucinations, it's not quite as reflective as it is with of their life as adults. It's not quite hanging together. It's harder to translate, I think. They're more disorganized and harder to put into a particular diagnosis, you know, like affective or plain schizophrenia or whatever else. It's hard to put them into a discrete category. And it's a lot harder to treat because adolescents, of course, their job is to individualize. It's to break off from the family and find their self. So they tend to be resistant, but for good reason. That's what their developmental job is. And so it's harder to reach them. They want to be their own person. Unfortunately, if their symptoms are still showing after 6 months, the prognosis is not very good. If recovery happens, we usually see that within the first 3 months of treatment. So the best predictor of how treatment resolves is within that first 6-month period of treatment. So those of you who are working with clinically high-risk populations, this is really something to keep in mind. Also, when we see it bloom from adolescence, there's generally more of a likelihood of familial mental illness going on. There's a handout on this. I thought this was really important for differential diagnosis: substance abuse, conduct problems, personality disorders, trauma, the hallucinations that are not drug-induced hallucinations. And sometimes hallucinations can be over top of perhaps another diagnosis like autism or depression. So we really need to be careful of that as well. I loved this chart here. This is Erik Erikson's Stages of Development, if you'll remember from Psych 101 back in the day. And here we have the existential question that normal adolescents go through, whatever normal may be, but you know, the mode, the modal thing to do. So, you know, can I trust the world? Is it okay to be who I am? Those are all natural adolescent questions. But when somebody is trying to break through that developmental period and master those skills, it's much harder and way more confusing. It's not just, can I trust the world? It's, can I trust what my own eyes see or what my ears hear? Not understanding why people are critical. If you'll remember, affectively, people with this condition have a hard time reading their own emotions, reading other people's emotions. It's like a whole segment of communication is kind of cut off. It's not like they don't know that they're different or that they're awkward or that others are treating them differently. They know that. And can you imagine? I mean, I had issues over having a pimple on my nose. I can't even imagine what it would be like to consistently be treated awkwardly and to feel awkward in a group of my friends as an adolescent. Difficulties with learning, difficulties with socializing. Parents don't know what to do. Oftentimes they're criticizing because of the negative symptoms that are there. And quite frankly, at some point in time, this adolescent is, you know, becomes to wonder, you know, is it all over for me? It probably is. I'm not good for anything. What's going to happen to me for the rest of my life? And so we see a lot of then self-destructive behavior as that moves on into adulthood, because for them, they can't see a way out. It does sound kind of bleak, doesn't it? But there is something that we can do when we see this in adolescence. So a real big, huge part of this is identity versus role confusion, which is that big adolescent period. Symptoms are insidious, so you may see things that look like OCD. You may think you see depression, right? So if you've got somebody mentioning, well, I hear things sometimes, or sometimes I see things out of the corner of my eye, or maybe this is a concussion from soccer. My son's had concussions from soccer and had headaches, and is it because I've been traumatized? Well, maybe if we take care of that, everything else will go away. No, we don't know at that age what we're dealing with, but we know that there's something there. So a lot of the work with adolescents is really to help them discover what their role is in the world and how to make their life meaningful, what to look forward to as an adult, and how they can empower themselves to continue to run their own lives as best that they can, even with this disorder, right? So keep in mind, somebody who's an adolescent, they're showing these symptoms, they're still under the purview of somebody else who tells them what to do, takes them to places not necessarily with their permission. You get thrown into a hospital. They lose control over decisions in their own lives. When you get to the hospital, they get to you, they're clamping shut, right? And so the name of the game is to engage, be where they are, and go very, very slowly. Adolescents tend to prefer a more conversational style as opposed to a directed CBT style. So if you're more comfortable talking about other things rather than the disorder itself, that's kind of the way to go. And then you can begin to add in some of that reality testing, just a very little bit at a time with those questions. What do you make of that? I wonder about that. without giving the answer, just a wonderment, drop the seed. And if you've been able to develop a good trusting relationship, they'll come back to you and wonder about that seed that you dropped before. We also want to work on autonomy versus shame and doubt. Okay, that basic trust. This is a tough one, guys. So remember, they're likely being criticized by teachers, by parents, maybe by employers. Their trust in the world is not going to be good. Maybe they're feeling abandoned by all of the people who should be supporting them or who they believe should be supporting them. And it's doubt and shame everywhere. You know, we grow up thinking that everything is about us until we learn to separate. But if we can't separate appropriately, we can't master those tasks, then we carry that shame and guilt with us in terms of I can't master anything anymore. Parents sometimes will distance themselves from the kids. Other parents will tell their kids not to play with your kid if there's a developmental disorder going on or conditions like this happening. These poor kids get isolated, you know, way too soon. So it has to be okay to be them when they're with you. It really needs to be so safe and so comfortable. So using humor is often a good way, appropriate humor, of course. So basic issues of trust include, can I find support and nurturing from other people? Can I find something to do in this lifetime that's going to be meaningful for me? And figuring out how to determine what part of themselves that they can trust in order to make those relationships, make those decisions, to build resilience in them and have them be able to count on that. So we need to take them back and kind of help them master skills in adolescence that they haven't been able to master before. And that's not a lot about hallucinations and delusions. That's about mastering a developmental task like social skills or communicating or presenting in front of others or taking a test and being able to stay calm while they're doing that. If they can't master these tasks in some kind of way, they're just going to end up believing that they're damaged goods. You know, again, back when we were kids, it was, oh my God, I have a pimple or I don't have a date to the prom. For them, it's, I'm being put in a group home. I'm being asked to leave my house. I'm being put in a hospital. Those are huge traumatic events in and of themselves. Much bigger questions than what the average adolescent is having to face these days. So go back to the stages of trust versus mistrust and work it along, helping them to master those developmental tasks as you move. You do want to educate them about psychosis in a way that keeps them not afraid of it, right? So normalizing is going to be really, really important. You know, keep in mind, 8% of our population hears voices, but only a wee part of that 8% is something that we call schizophrenia, right? And so we need to normalize as much as we can, introduce celebrities, people who have made it in life with this diagnosis, trailing along behind them. Along with all of this, the disorder tends to be much more severe in adolescents than it is in adults. So we want to work on self-care tasks. Cognitive behavioral social skills training is really, really important. Eric Granholm has a great book with others. He wrote with others about mastering social skills. Harry and I used it with a group of adults who were in a 16-week group. Oh, they loved that part of it. Every time you see an opportunity to reduce shame, do it. Every single time. Involving family is necessary for the education of the family as much as it is for the adolescent. We cannot leave the family out of this at all. We can't just say, well, I've talked to them, you know, once a month. That's not good. These people are needing to have the education to be able to do a little bit what you do in the office with their child, and always allow them as much independence as possible when they're with you. Okay, where do they sit? What do they want to do? What do they want to talk about? Therapeutic tasks involve engagement, presenting a diagnosis as a possibility but not a certainty. Or we may think about presenting other diagnoses that are less stigmatized, that fit, right? So PTSD might be one. Depression might be one. Focus on immediate concerns rather than the whole disorder. Address issues of stigma and how to manage that and save face, right? So if they're feeling like they want to talk back to a hallucination, let's help them figure out how to manage that urge and save face at the same time. That requires a lot of trust then for the adolescent to even admit to you that they're hearing voices, right? So there's a lot of work that goes into this. And anybody, any therapist or case manager that has any stigma issues about this probably should be in treating a different population. There are still some of us that do hold that simply because I think we lack the education. You've got a handout on this, so I'm not going to review this too much, but there are these developmental tasks in adolescence from this Center for Health Communication from Harvard. These are lovely tasks, and it's important to help them reach some of these, if not all of them, but that would be tough. We need to be prepared, guys, to talk about really difficult information like, well, drugs and alcohol, we're pretty used to that, but sexuality is really important too. Intimacy is important. How do you deal with friends is important. How do we deal with LGBTQ issues or racial issues? These are issues that adolescents really want to talk about. Have somebody to talk about with them that they can trust. So we also need to be prepared for preparing them for independence, making a budget, managing their bills, how to take part in family responsibilities and chores, how to take care of themselves through exercise and eating and lifestyle. And they need guidance with this. The family probably is not able to do that in its entirety on their own. They really need you to do that. If there's a chronic health condition, that adds more to it, but it also gives you the opportunity to really help them through a whole lot, right? But we need to be aware that there's all of these things in this even more complicated disorder now that you've got adolescence in front of you, right? So it's continual encouragement, continual patience. Sometimes we have to renegotiate family relationships because families are uneducated or have not heard, or from a different culture where they view mental health in ways different than the way that we view it. So families may need a lot of education and guidance as well. I really love in a program called Open Dialogue, which began over in the Netherlands, where therapists would actually go in to the home and just hang there for 2 weeks and help the family through. To me, that makes really so much sense, and I'm hopeful that Open Dialogue really makes its presence known here. Factors that influence treatment. Adolescents tend to be more sensitive to antipsychotics and the side effects of that. As a whole, they tend to be more resistant just because of their developmental stage. And there may be neurodevelopmental disorders like learning disability, autism, those kinds of things in this age range as well, that word ADHD. So it's a lot, it's complicated. There is a higher prevalence of cognitive impairment, again, or delusions are less organized. So family intervention is required at every stage of the game here. I'm not a doctor. I'm not that kind of a doctor anyway. I'm not a medical doctor. So we need to be aware of how antipsychotics affects a teenager's metabolism, right? There's weight issues, there's cholesterol issues, there's sedation. Some of that medication makes you drool or be incontinent. I can't imagine what an adolescent would be feeling with all of that on board as well. Movement disorders, right? If we're moving from one antipsychotic to another, abnormal development, for example, young boys developing breast tissue, which is rare, but that can happen at some point in time. So these are things that really need to be talked about. So increased prolactin is the issue that will create some metabolic issues and developmental issues. It really causes a drop in libido. It can cause that breast development, particularly in males. Suicidal ideation and behavior can occur more often in adolescence, and sexual responsiveness is different. Now, as much as we'd like to think that our kids are, not messing around with sex before they're fully adults and know what they're doing, we all know that that's probably an unrealistic hope. And so we need to address this before they fall into a hole and do it without judgment. And allowing medical personnel to tackle those things are sometimes the best way to go, but that means you need to communicate with your physician that's on your staff. So that's a lot. You do have, I think, 5 handouts from this. I know I went through very, very quickly, and I'm wondering if you have any questions before we sign off from